Welcome to Health System CIO's interview with Scott Raymond, Chief Information and Innovation Officer with Nebraska Medicine. I'm Anthony Guerra, founder and editor-in-chief. Scott, thanks for joining me.
Yeah, my pleasure, Anthony.
All right, great. Looking forward to having a fun chat. You want to start off by telling me a little bit about your organization and your role?
Sure. So, Nebraska Medicine is an academic medical center in Nebraska, in Omaha. We're part of the health system. So, we have our academic medical center on campus at the Medical College of UNMC, and we are connected at the hip essentially for that, for education, research, and clinical care. We have a community hospital about 15 miles to the south of us that we manage as well. We have about 150 ambulatory locations across Nebraska. The other unique thing that we do is Nebraska Medicine hosts Epic for 4 rural hospitals out in Nebraska. We're kind of the main default county hospital, state hospital, and we're a level 1 trauma center. We have about 20 to 30,000 employees that we support. That's inclusive of the university. So the UNMC campus has the medical college, the nursing college, the pharmacy college, College of Public Health on campus. So that's our main campus.
All right, very good. So, the hosting of Epic for the 4 hospitals, is that quite an undertaking? Does that add a lot to your plate? Or maybe the first one does, and then it kind of gets a little easier adding 2, 3, and 4? Just tell me a little bit about that.
Yeah, so the cool thing is we leverage a single instance of Epic to manage all of the hospitals, including ours. We divide out the campuses by service area. So basically, essentially containerizing their patients within Epic. And so we don't cross patients. We don't look up their patients. They can't look up our patients. From an infrastructure perspective, the planning of it originally, when we started to do this, we had to take into account the number of users, concurrent users that would be using, let's say, let's just talk Epic first, to support those other organizations. The other is we stood up, made it a program, right? So we have a programmatic approach to it. So we have FTEs that support that. So the setup was, I wouldn't say it was too difficult. We follow kind of an Epic roadmap for that. We are very standardized on our approach. The other cool thing we did with our Community Connect partners is we've allowed them to have their own builders. So we call them community builders, which takes the kind of frontline request and support and puts it in the hand of those hospitals. And then we support with our analysts on the build. And then we also support their projects. So a recent example of that would be pump integration, so IV pump integration. So we've done that at Nebraska Medicine and Bellevue, our community hospital. We allowed them to do that pump integration. So we supported, like, with project management and technical help to stand up that for them. So at this point, it's really a well-oiled machine. I think planning is everything in how you support it, and keeping your services in a common kind of foundational way has made that successful.
Yeah, it's very interesting what you talked about with the pump integration. John Halamka, with the Mayo Clinic platform, I'm sure you heard of him or
Yeah,
know
I
him.
know, John. Yeah,
Yeah.
yeah.
So John has, when I interviewed him recently, I've known him forever, and we talked about the concept of determining what you should be doing on the innovation front based on your size and your sort of complexity and your ability, your resources, and kind of easily, at a simple way, broken into 3 buckets. The top bucket would be an organization like yours that really wants to be doing new things and pushing the envelope. And then in one of the other 2 buckets, it probably depends which one, would be the organizations that you're supporting their Epic instance and you're innovating and then you're sharing that with them, which is interesting. And I'm sure there's a financial element to all this where they're charged for the support and they're paying you for the support. So it's not like, you know, donations. Um, but that is an interesting concept. At least this innovation among the upper tier, the academic medical centers, and then hopefully, if not directly through the way you're doing it, indirectly, those innovations sort of percolate out into the rest of healthcare. What are your thoughts on that kind of dynamic?
Yeah, no, I agree with what you said, and I think that's our goal. So, we do charge for the service. It's not a money making, it's not like a profit center for us. We try to keep the costs nominal. We also see it as a community benefit.
Mhm.
We also get a lot of patients since we're the trauma center and we have all the specialty services on campus. We get a lot of transfers from our partners. So there's a shared benefit in all of this. But I think the interesting thing you talked about is the shared technology. And we've been trying to do that too, because it not only raises the level of care and the level of sophistication of our campus, but we have the opportunity to raise the level of care and sophistication out in the community, which also benefits us, right? So if those hospitals are better able to take care of those patients and not have to transfer to us, we all stay in a good operating space, right? We're not going to get overwhelmed from them sending us everybody, and it allows us to have space for that specialty care like cancer care or endocrine care or orthopedic care. So we do that holistically. And I know it sounds, maybe a little pie in the sky, but because we do charge for it, but it really is not like we're not trying to make money off of it. That wasn't the impetus of the program.
Yeah, and it's okay. Like we don't maybe we don't want to make money, but maybe it's okay to make a little money because there's no
Well, it has to be
margin, no
sustainable.
mission, right? No
Yeah,
margin,
yeah,
no mission.
yeah.
Um, so yeah, and especially when multiple things are being accomplished at once, right? It's good for you, it's good for them. That's the win-win everyone looks for, right?
Yeah, 100%. Yeah.
Um, okay, couple questions. You mentioned the containerization element of the instances you're supporting. Um, Also that some of those patients are, of course, winding up in your health system from time to time. So where does that leave you in terms of being able to, the huge benefit is if you can see the record, that's what we all love, but that's what you get when you're moving within a health system, right? That has a large instance of one EHR. That's one of the benefits. You go to the physician practice, they have your record. You go to another physician, they have your record. You wind up in one of their hospitals, they have your record. It's beautiful. We all love it. Does the containerization prevent that, or how does
No,
that?
it really enables that. I guess I should have been more clear. So when you have your own service area, like the financials and the business side of it, it stays with them.
Ah,
But if a patient is a shared patient,
mhm,
so they've been to the medical center, our physicians and their physicians have full access to that chart. Epic has been pretty good with care anywhere and care everywhere. So the ability to connect those patient records for continuous or care continuum is really strong, not just in Nebraska, but we get patients from other states, we get patients from other countries. So our ability to share that information and give access, and Epic is good about the security of that. If you are treating a patient, you should have access to that record to best care for that patient. That siloing off of the patient record for care, um, that hopefully is in the past for most of us.
mhm,
Um, and we can do that through that care everywhere with even a Cerner shop or through an HIE. So we have the ability to see the patient's record and get that historical information to do better care. Really, that siloing is the business operations. Like we don't look at their financials. We don't.
right.
They keep their own service area, so they operate as like an independent organization, which they are. That we just share the EHR. So it is containerized, but the actual ability to care across hospitals is completely integrated.
All right, very good. So let's build off the idea of the pump integration. Would you describe that? And this is very interesting to me. In you've got innovation in your title. Everybody wants to be innovative all over the place, which is great. I guess innovation, you know, and it's interesting defining innovation. If you asked 20 people what innovation is, they'd probably get 20 different answers. I read a post, a LinkedIn post by a doctor who's very smart. I think his name's Graham Walker. Um, and he said he thought innovation, a good definition was either bringing two things together that had been separate or eliminating a step or something like that. But it was quite a simple definition of innovation. Maybe at some level, it's just solving a problem in a new way that we couldn't solve before. So a sticky problem that everyone wants to address and we haven't figured it out. So let's try, and maybe that's innovation. But what are your thoughts? What is innovation? And then I want to sort of get into, because I think there's a formula here for how to do innovation right in a health system, in a way that's efficient and not wasteful. But I'd like your thoughts. Tell me how you think of what innovation means.
Yeah, those are great questions. And I might not have the perfect answer, but I've been in this space at other health systems. I ran innovation labs. We had a for-profit innovation fund, and that kind of formed or shaped the way I look at innovation. And I agree with your definition. Innovation to me is a novel approach to something. And whether that's combining two things or getting rid of something or looking at maybe a net new technology that solves a problem. Kind of what we have grounded ourselves at Nebraska Medicine is we don't want to do innovation for innovation's sake, right? I think there's a lot of companies that do that. They're trying to come up with some novel concept and they're trying to, give you a solution for a problem you may not even have. And so we're looking at what problems do we have in the health system? Do we have a application, a software, or a system that solves that problem? And maybe we need to redeploy that or transform the way we're doing it to solve that problem. From an innovation perspective, if we don't have a solution in-house or another company provides it, we would look for an innovative way to do that. And I think we're really focused on the problems we're trying to solve. And we push from an IT perspective. If you're looking for something new and you don't understand clearly what your problem is, and you can't articulate the capabilities you need to solve that problem, then you have no business solution hunting because you're going to bring something to the health system that maybe my infrastructure can't support. Maybe the workflow is not conducive to the way we do business. So I think I like to say we are focused innovation. Innovation's in our values, so it's part of our values. It's the first letter in our values. So I think, and as an academic, we are trying to solve problems, right? We're coming up with new procedures, new medicines, new devices to solve problems for patients. And I think we are very focused on that mission. And we can talk more about, you brought up the IDU, we can talk more about the IDU and how we're actually taking that concept and putting it into reality and putting it into work.
Very good. So it's interesting. And I always think of the iPhone and Steve Jobs when we talk about innovation, but that's not the kind of innovation we're talking about here. Theoretically, the iPhone was Steve Jobs introducing something better that nobody knew they even needed, right? So that's not what we're talking about here. We're talking about solving identified problems, usually that bubble up from the users. So it's, I wish I could do this, or this takes me so long, or I have to copy and paste this from here to here. I don't have the information from this system when I need it over here. So that's a different type of innovation. That's solving identified problems. It sounds like that's what healthcare wants to focus on, as opposed to these, nobody's identified a problem, but I can envision a way to do this better. So am I correct in saying we don't want to do that? We don't have the margin to do that. We don't have the time.
Yeah, I think that's accurate. I do think we look at novel approaches from our research folks. So they're looking at new ways to treat patients. They're looking at, new ways to cure diseases.
Right.
I think those novel approaches are what we need to advance medicine 100%. But I think when it comes down to delivering care, you have to be a little more focused and specific. And there is a utility for that, and we can start bringing those in because if someone comes up with a novel drug that cures something, we would want to be one of the first to ingest that into our health system and to make that happen. I think where technology gets a little slippery, right? Because kind of to my point, if no one can articulate the problem or the capabilities, I could give you a tool, and if you don't use it, then I've just failed, really. And
Hmm.
I think that's our other kind of goal for us is we want to fail purposely. Like if you're successful with something, that's how you operationalize or transform something. If you fail, you learn something, and you start to iterate on a solution for a problem. And I think that's where we're set up really nicely with our IDU and our new unit and how we're going to build our new hospital. So I think we're set up to do that, and that's kind of our goal.
All right, let's talk about that a little more. I mean, failing's okay if we haven't been foolish, right? If we've been thoughtful. If we've
Mhm.
been thoughtful and we have a governance program, we have parameters, we have methodology for trying things, and we've defined risk levels and we've defined appetite for investment and we've defined appetite for change, and the ability for users to try new things because we don't want to overload the users. So if we've come up with all these parameters around innovation and piloting, and something fails, that's fine. I guess we do a post-mortem, see if we want to adjust any of our procedures because we could come out of it and say, well, that was a complete waste of time, and we don't need complete waste of time. We want things that are at least on the cusp. But give me your thoughts there on architecting an innovation program around pilots and startups and trying new technologies to solve identified problems that gets you there to where the things you actually move forward on had good reason, even if they fail.
Yeah, I think foundationally you need a place to do that work. It's very hard. I'll give you an example. I worked at a health system in Southern California. I was in charge of innovation and technology for the system. I did most of my pilots at our smaller community hospital and not our teaching hospital because of it reduced complication for me. I did most of those pilots in the hospital in the units. It became increasingly more difficult to impact operations with
Mhm,
my projects. I
mhm,
had to get buy-in from the nursing leadership. I had to get buy-in from the nurses on the floor or the technologists on the floor to do this stuff. So we built a lab outside of the hospital. That lab was fantastic because I had technology, I had a footprint, I had a data center that could support a 2,000 bed hospital. I had open lab space where I could create a patient room of the future. I could create a nursing station, an OR suite, and we could iterate both on workflow, devices, and technologies all in a single place that didn't impact operations. Um, I had to bring folks over to run them through their paces or to get physician feedback, um, and it worked great. That innovation lab became a profit center for the organization. They rent out the space. They rent out to technology to test against our technology or their applications. Very successful, still successful. So when we were looking at Nebraska medicine, we had a couple of problems we were trying to solve. The biggest one is how do we build a new hospital that's future proof? And in that, I mean, how do we build a hospital that it's not obsolete the day it opens? That happens to a lot of new hospitals, a lot of new buildings, because a lot of that planning technology and the way you build it was planned 5 or 6 years before the actual digging in the ground, right? So we decided to preempt that by building an innovation unit. So a 17-bed unit that's going to be a novel unit. We call it the innovation design unit on purpose. We have we are taking care of live patients in that unit. Every nurse and every person that was hired there knows that we're going to be doing innovation. Their cheese might move, probably not on a weekly basis, but maybe a monthly basis to try new technologies, new workflows. And we can take our ideas and test them in the real world. So taking that lab concept that I had in Southern California, but making it grounded in real patient care. So adjacent to that unit, we have our what we call our bridge space, which is our innovation lab. And we can mock up things, we can try things. We have a room in there we call the sim room that's an identical copy of the rooms in the unit, and it's full functioning. So the gases work, the Wi-Fi works, the beds work, all the monitors, everything works in there. So you could put a patient in there, and we can try net new things there. And so the goal is to try things, see if it works, and then bring it into the unit for that real world test. And if it doesn't work, then we can bail fast. We can get
Mhm.
out and try something new. Um, so that unit opened January this year. Um, we've already tried a lot of novel things in there already, and kind of three main technologies we're piloting. And I'm going to tell you what they are, and you're going to say, "Well, wait a minute, Scott. Those have been used already." We're using them combined in a novel way, I think, to prove out a different care model. So it's not only building the room that's going to be future proof, but also we know that we're going to have to change the care model because there's less doctors, there's less nurses, there's less money to care for. So how do we do things more efficiently? How do we do things differently? And I'm a nurse by background and training, so I was a pediatric ICU nurse. So I've lived kind of both sides of this. And I started out my nursing career in team nursing. So you had a nurse, you had an LVN or an LPN, and then you had a nurse's aide, and you took care of 10 or 11 patients as a team. That went away to primary nursing. So then the nurse got less of a load, but did everything.
Yeah.
That's been the model for the last 20 years. That's not going to be sustainable because we just don't have the clinicians to support that. So we actually are going full circle. So what is old is now new to a team care approach. And so in the IDU, we are using virtual nursing. So
Mhm.
that's a net new technology for us. Again, not novel. We're using a very advanced patient engagement. So with Vibe, as part of a combined system with the virtual nursing. And then we're using advanced RTLS to track patients, people, devices, everything. And then our goal is to take that data together and to look at ways we can iterate on those technologies to provide better care. And so that is live, those new technologies. And again, they're by themselves, they're not novel, but the way we're looking at them is a novel approach. And it's all about how do we care for the patients better, um, despite the way we have to change the care model. So the virtual nursing has been super successful, and we've already moved it out into another unit of the hospital. The goal is to move it out into another unit of the hospital soon. Eventually, if it proves out, we would put it into every unit in the hospital. And then that would become a core technology for the new hospital that we're building. So on site, we're building a 2.5 billion plus new tower that will take care of patients for the next 50 years. So the goal of this IDU is to inform not only how we build the patient rooms, but
Mhm.
also how we do the care model redesign.
You wanna, talk at all about any of the technology you're using in that Vibe Health Smart Room?
Yeah, so Vibe has been instrumental for us in a couple of ways. So providing real um, patient-facing interaction, not only with their environment, but with their care team. We have deployed iPads that are part of the system at the bedside. They can adjust their environmentals, they can order their food, they can interact with the nursing staff. With the other cool thing I think is, which is a huge leap for us, is they can interact with loved ones. So if they have they have their spouse at home, they can have Zoom meetings with the patient and with the physician if they're doing rounds. Like you can include the patient's family member, loved one, or whoever's might be in charge of their care. And having that fully integrated within the systems of that room, including the RTLS, including the virtual nursing, I think is going to be a game changer. We've already had great feedback from patients. We had one of our first patients that got admitted into the IDU, and she got readmitted, I don't know, for a different problem, so it wasn't a readmission.
Mhm.
And she was hoping she got in the IDU, and just by abstinence, she got readmitted in the IDU. She's like, "Oh my gosh, once you're here, you don't want to stay anywhere else because
Mhm.
it's just a completely different experience."
So, the Vibe Health, smart room, and you're using, Ividion? Are you using
Yeah,
that?
that's
And
the
what do
core company. Yeah,
okay, okay, and that's for the, that's the platform that you're using there?
yeah, for the patient engagement, and
Okay.
it's a little more than just that. So the it provides a whiteboard. So, in
Mhm,
the old days, they used to write on the grease board and who your nurse is, what time your stuff is. So that's now integrated within the chart, integrated within our staffing. We're trying to integrate it within the RTLS as well. So if you walk in the room, it'll put your face up on the whiteboard and said, "This is your attending physician, John Smith. We can have your schedule. You're going down for MRI at 3, you're going down for therapy or whatever it is." So the patient has a in real time schedule of what's going on and can see who their care team is at any given time. So not only the ones that are there for the day, but the ones that come interact throughout. Because we are a teaching hospital, so we have attendings, we have residents, we have students coming in and doing rounds. So from a patient perspective, you sit in the bed and people come in, you wouldn't even know if that was the nurse, the doctor, or who it is. Now it's clearly identified in that system.
right, so the Innovation Design Unit, did you say there's 17 beds in there?
Yeah, 17 beds, and I know that seems like an odd number, but but you have to give us a little break here because we put that unit in a 60-year-old tower. And so we
Mhm,
took a floor and completely demoed it all the way to the iron girders and then arranged the unit so we had a central core, so a collaboration space. So forget the kind of the old school nursing station and the way that was set up, and having your EKG tech sit in another room, have your physicians outside of the room and their collaboration. It's all in one space and it's
mhm,
very collaborative. So that was the goal, to have that central collaboration space down the middle of it and the rooms around the outside of it. And the other kind of thing that limited us is we wanted to try different bed configurations. So the unit setup is 17 beds, but they're in 3 pods. So
mhm,
we have one pod that has all right-handed rooms, and they're all single occupancy that can convert to double. So in a surge thing, we could put 2 patients in there. Another pod has left-right rooms, so they have mirrored rooms. Then we have another unit that's set up really like an ICU/procedure room. So there's booms and OR lights, and you can do even advanced procedures in there. The other model we're going to test out is, could you have an ICU patient in there and transition to step down and then transition to med surge, but never have to leave the unit? And
mhm,
so we're trying that concept to see if that's how we build a new hospital. So do we not build room configurations differently on the 20 floors? Are they all going to be a similar configuration, and can we look at that transition of care model where you're not like moving someone from the 7th floor down to the 3rd floor? They can stay
mhm.
on the unit and the care or the level of care changes, but the patient doesn't have to move. That might not end up to be how we build it, but you wouldn't know that without trying it in real life. And a lot of places that are building a new hospital aren't afforded that ability to try it before they buy it, right? So I think
Mhm, right.
that was a kind of like, again, that's another goal of it, is how do we build that hospital correctly this time so we're not obsolete. And I was involved in building an inpatient tower at a previous organization, and literally the day we opened one of the units, the nurses said, "This is not going to work for us."
Oh, no.
That's the worst case scenario. We just spent $1 billion on a new building, and it didn't meet the needs of the care that needed to be in there. So there was a lot of redesign work that happened.
Yeah. Just a couple of questions to clarify about the innovation design unit. I think you alluded to the idea that it's somewhat voluntary for the clinicians, meaning you said, "Hey, this is what we're doing over here. Would you like to come, work over here and give care?" So they could decide. They could say, "Hey, listen, that's not for me. I kind of want to just do what I do, and I'm not really into trying new stuff." So, if you can clarify how that worked, and I suppose not only on the nursing side, but also the physician side, and also on the patient side. There are real patients in here, sounds like. Do Are they told, "Hey," you mentioned the one coming back was very happy to come back, but first time around, are they told, "Hey, this is something we're doing over here. Would you like to be over here, or do you not want any part of this?" How does that work?
Yeah, we're not consenting to be in that unit for the patients. We have a consent, a general consent because we're a teaching hospital.
Okay.
And from a staffing perspective, we were very purposeful in being transparent of the type of job this is going to be. And so it was right up front in the hiring process. This is what this unit is. This is what it's going to look like. This is the purpose of it. This is what your world is going to look like. So basically hiring folks that love change and are not change averse, because you wouldn't want to hire somebody, to your point, that, like, I didn't know that we might change the way we take care of patients. That doesn't work for me. I like to do it this way. So I think just the clinical leadership in that team did a fantastic job of hiring the right people and being very open, honest, and transparent about what that environment was going to be.
Were people able to transfer existing employees?
Yeah,
Oh, yeah.
we have a lot of folks that transferred to that unit, and we're excited about it. Like, they looked at this as a huge opportunity to advance their practice, to try out new technologies. So I think that side of it, I have to my hats off to Kara Tomlinson and her staff for hiring and setting up a program that is just amazing. And I think if you went in there and interviewed that staff, I think they're all super excited to be there and proud to be there. Like, they know that they're on the cutting edge, which is super cool.
All right, I'm just gonna ask you one or two more questions, and I'm gonna let you go, Scott. But I think you could be really helpful to a lot of our readers and listeners. I get the sense that some people are struggling um, with managing innovation in terms of pilots and things like that, and doing it right. There's a lot of you get bombarded as an IT executive. You're getting bombarded from your users with requests that maybe they're suggesting technologies. Someone has approached them at a trade show or whatnot, and they're excited about an application. So you're getting it that way. You're getting directly approached by vendors, existing vendors who want you to try their new stuff, and vendors you haven't worked with yet. So you have a lot coming at you as an IT executive. You want to try things that make sense. I would assume that very few are probably getting it exactly right in terms of cadence and taking on the right projects. Probably people are either taking on too many projects, and maybe a lot of them are failing, or they're taking on not enough projects, and their colleagues don't think they're being innovative enough. So it's kind of a Goldilocks thing. But what's your best advice to the IT executives out there about how to be thoughtfully innovative in a scalable, manageable way, sort of hit that Goldilocks spot?
Yeah, I don't know if I have the perfect answer. I can just give you from my experience. I think the number one thing is you have to have an environment that you can do this in. And that environment should be able to afford you kind of real life results, but not impact operations. Because, as you know, the margins are thin, and it's very difficult to displace people or change their work or change their ability to take care of patients. So you need a place to do this. The second thing is you need the resources to do this, which is also another hard thing. But if you're taking people away from their day jobs to do innovation, it's very difficult. You can do it, but it's very difficult for them to focus or to give the amount of time it needs.
Hmm.
I think the other big thing that we've done in the IDU is we have a PhD level scientific director who is really big on the resource management. And so we have an innovation operating model. So we have a um, process for intake, we have a process for ideation, we have a process to run the innovation, and then we have a process to move the innovation either into production or out of the environment. And I
Mhm.
think having a system, and we're going to iterate ours over time, but having a system and following it is super helpful. So have a place, have the resources, and have a process, a solid process to manage innovation projects. So we have a separate pipeline for it. We have a separate team that evaluates it. We have a separate innovation operating model. And we haven't, it's just open, so we haven't done a ton of it yet, but we're already running. I think we have 5 or 6 projects in the queue that we're going to start running through there. So I think those are the key pillars, I think. um, you can do the innovation kind of the old fashioned way and go into a unit and say, we're going to give you, nurses new phones, or we're going to give you a new clinical
Mhm.
communication device, or whatever that might be. But you're just know you're going to impact your productivity. And if everyone's okay with that, that's fine. But try to find a way that you can do this super efficient, because that's how we have to operate, not only on how we manage the hospital or the health system, but or patients, but how we manage our resources. So asking people to do extra is not always a great plan.
Makes sense, Scott. Listen, this was amazing, Scott. I want to thank you so much for your time today. I think our readers and listeners are really going to appreciate it, and hopefully I can catch up with you down the road. So thank you
Yeah,
very much.
I look forward to that. Thank you, Anthony. My pleasure.
Take care.